Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast is to bring you short educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment and the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job in caring for people living with dementia and connecting them and their care partners to the things they need. Good afternoon to everyone, and thanks for joining us on Dementia Care on Air, our podcast where we go over dementia topics. And very pleased to have today Dr. Serggio Lanata, who just did our webinar in January on dementia prevention and care for Latinos in San Francisco, talking about his clinical and outreach work. I'm going to ask Dr. Lanata to introduce himself. I'll probably start calling him Serggio. And then we're going to talk about some of the main points from the webinar and what we learned together. So welcome, Serggio. And if you would please just briefly introduce yourself and your role.
Hi, I'm Serggio Lanata. I'm a behavioral neurologist and neuropsychiatrist at the Memory and Aging Center at UCSF. Where I see patients. I do clinical research in Alzheimer's disease and other age-related neurodegenerative disorders. And I also have some mentoring or teaching roles here, as well as outreach.
Wonderful. Thanks so much. And I think what I was hoping to get started with is if you could go over again, the webinar is out there and the video is posted, but go over again kind of where you started the webinar with, what we should be thinking about, how we should be thinking about the Latino populations that we serve, obviously in San Francisco, but also in California.
Mm-hmm. Well, maybe I'll just start with sort of a narrative of how we began this work. I think one of the things that struck me when I came to UCSF and started working in the Memory and Aging Center as a fellow was that I wasn't seeing a lot of Latinos in my clinic, which was quite a different experience from what I had when I was in training in the East Coast, where I did see a lot of Latinos come to my clinic. And so that prompted, a little bit of research into what was going on, what were the barriers, and, first of all, what's the reality of representation of Latinos and other minorities, let's say, in our clinic. And that's how I came up with the approach of looking at our own data, meaning let's find out where people are coming from to our clinic. And I found that in those areas of the city that are highly represented by Latinos and African Americans and Asian Americans were the least represented in our clinic and also the least represented in our research center. And so that data-driven approach or that data-driven insight led to an approach to outreach, which was to plug ourselves as much as possible into these neighborhoods so we can reach these populations. When it comes to Latinos specifically, I think one of the important points that I think that I try to transmit in the webinar is that everything that we do here when we try to reach Latinos is pertinent to the Latino population that lives in this area, which may be extremely different from the Latino population that you serve in your area, right? And that's an really important point, I think, to keep in mind, that when we speak of Latinos, it doesn't make sense really to cast a broad net of generalization, even in our state of California. Because, for instance, most of the Latinos that we serve here in the city have a very quite low socioeconomic or economic well-being, let's say. The majority of them are monolingual, and that may be very different from the population that you're serving, say, in another big city like LA in California or in some eastern region. So it's very important to get to know the communities that you're serving. What are their needs? What are the sort of average sociodemographics? And try to tailor to that,
Thank you. I think that's great perspective and really helpful. I mean, I know here, like clinically, something we're always having to think about is sometimes, they're from a region of, Mexico or Central America where Spanish isn't even the first language. That's, it's a second language. So when we're thinking about evaluating the brain, for example, that becomes really clinically useful. And then you and I both work with the neuropsychologist who always helps us think about the historical, cultural context that people are from. Like we have so many folks who came from El Salvador, and so the issue surrounding the circumstances of them leaving become really important. Nicaragua, same thing. So yeah, I really, really helpful. How does your outreach work sort of help with that, or kind of help bring the context of the person and their full background, I guess, to the clinical environment where you're hoping to encourage them to come, or even the research environment?
Well, what we're doing is we're trying to meet people where they go and having both like intimate, you can say like small group discussions, and also big meeting spaces where we educate and we bring our knowledge around the brain health into these communities. And that experience, I think, informs also the way we practice, right? The way I practice. You start to get an increasingly accurate average of the Latino population here in the city, the more you do this type of work. And that informs, how you behave yourself and what type of approach you take when you're meeting someone in clinic. But so the way that we're doing things, is we're doing like traditional lecture-based education or talks. We're doing small group activities. We're doing workshops. We bring arts into the mix to try to create more intimacy and small group discussions around brain health. What I say is that we're trying to build brain health literacy because clearly here in San Francisco, especially when you're working with older adults, there's a high prevalence of low educational attainment, and if they have education, sometimes it's not the way that you tend to think of education, right? So it's education acquired in a very rural setting of Mexico or El Salvador, where school only went half day, 3 days a week. And so it's not sufficient to just ask how many years of education you have. You gotta try to delve a little bit deeper. And that is something that we do in our clinic, Anna, in the GNCC, in the Geriatric Neurology Cognitive Clinic, where we're interested in like getting as real as possible an assessment of their educational activity, because together with their life course experiences, that matters when you're evaluating someone and giving an assessment, right? So if you're seeing someone that has on first questions, yes, I have 10 years of education, but then you dig a little deeper and you find out that, yeah, but they really went to school only 3 days a week, or the quality of the education that they received was really poor, and this person can barely read and write despite having many years of education. That really informs your interpretation of a brief cognitive test, for example, which is something that we've highlighted in our work too, which is you can't rely on just a brief cognitive test, because especially when you're evaluating Latinos here in San Francisco, for example, you have to take a history. You have to really delve deep into the complaints, if there are any. You have to try to get a history also from someone that knows the person well, and couple that with your objective assessments.
So just to reiterate a little bit, it's sort of like the cursory history of what their education might have been, or trying to get a sense of what might be the right tool to assess, quote unquote, objectively their cognition, might really need to be folded in with sort of all the things we do to triangulate what's really going on with the cognitive concerns and complaints. Like, what information can I get about what symptoms are really prominent? What is the impact? So clinically, what do I think is really going on? So it's more of a, I'm just trying to repeat back, more of a clinical picture than just relying on these assessments and tools that we have that maybe have been adapted for people who, you know, perhaps even only translated from like an English version, or tools that have been developed in people who've had a totally different type of education.
Right.
So, and I think we keep bumping up against this, and the tools we're putting out there and the way we're trying to help people understand how to do these cognitive assessments, which is we can have all the tests all day long and you may still never have the perfect one to fit with that particular brain, you know, how it was educated, and how it developed. But really the important thing is this composite clinical assessment in situations like this.
Yes.
Did I say that well?
I think so. Yes, I agree. And yeah, hearing your reflection, I guess a conclusion that one can reach is that when you're evaluating certain populations of patients, yeah, you have to rely more on your clinical sort of impressions based on a history and, rather than on these objective scales that would be more valuable in a different population for reasons that are clear. I mean, another error that we tend to make um, is to homogenize. It's interesting because on the one hand, we value culture a lot, but we also fail to recognize that there's no such thing as a Latino culture, and especially when you're working in California, because, well, let's say when you're working in San Francisco, because that's what I know. Because here I meet people that come from all over Latin America. And I come from Latin America, from Peru, but I don't for a moment think that my cultural background is in any way similar to the patients that I meet at all. Um, I'm more similar to my cultural background is more similar to American culture, frankly, than to the culture of many of the persons that I meet. But I have the incredible advantage for them of knowing Spanish and being fluent in Spanish. So that opens up a whole new avenue of communication that otherwise I wouldn't have if I was English speaking. Um, and that's where the value is, that you can dig into the lives of these persons, dig into their complaints, their observations in a way that it's hard to do when you don't have the language. Um, so that's if you can build a team where a few people are Spanish speaking, that can go a really long way, I think, in helping being of service.
I'll extend your comment a little bit because I feel like you've said it really well before, and I really it sticks with me. You know, there's obviously a lot that we try to do in clinical care to bridge the language gaps with, you know, interpreters and professionals that can help. Of course, that's better, certainly better than not having that resource. But just the nature of working with people who are experiencing cognitive symptoms, it really doubles down on that need for people who are very skilled and preferably language concordant to sort of get the nuances and get the feeling. Like every once in a while, I know I'll work with an interpreter who's kind of trying to tell me about the nonverbal and like, or sort of cultural and linguistic cues that there's something going on, as much as they're trying to interpret the actual words that are being said, when they're sort of really skilled. And I've always really appreciate that, but it can be hard to do, you know, it can be hard to do. Can you say a little more about the outreach efforts and what the goals are of the outreach and what it looks like?
Yeah, simply put, I think the way we structure our outreach work is across three main pillars of action, we call them. Like we try to, in recognition that people are not coming to our clinic, in other words, that our clinic does not have anything close to an equal representation of different neighborhoods of our own city. In recognition of that, we started to step into community-based clinics, to try to bring our assessments into the community. And through that effort, I've learned subjectively, why is it that people don't come to our clinic? And the reasons are, very varied, quite varied. Sometimes it's just preference, people here in San Francisco, they like to stay within their neighborhood, or they're not able to easily leave their local environment. I'm thinking of, for instance, of the Mission neighborhood, historically Hispanic, Latino, and many of the older adults that live there don't have a car, and they have everything they need there, right? They go to the Mission Neighborhood Health Center. They do their shopping locally. So the incentive or the barriers to leave are quite strong when you ask them to just come to our clinic. That plus the language barrier and a bunch of other barriers, right? So, we made a partnership with the Mission Neighborhood Health Centers to go there and see people there. And we created a little triaging system where, the people that have a barrier or simply do not want to come here but want to be evaluated, those are the people that we see. But others do come to our clinic. And so we've taken that approach clinically of trying to go to the neighborhoods that are least represented. Then the other arm or the other pillar of action is just what I said before, trying to create, broadly speaking, like brain health literacy. And what I say what we say in our talks is, everybody a lot of people kind of know what's good for the heart, what's good for general health, what's good for bone health, even, right? And the liver, and people can make these comments, but when you ask, what's good for brain health, there's very frequently like a blank, people just are not sure what you're asking them. And, there's a lot of literature now on, these dementia modifiable risk factors. So we've taken that literature as an opportunity to act and to develop lecture series and, educational programs around these risk factors. And so we bring them out to these communities in Spanish, in English, and in Chinese also, and have these conversations. So there's a lot going around in education. And the most recent sort of pillar of action that we've adopted is doing these arts and movement-based engagements that have opened up a different channel of engagement, more hands-on activities. We developed these in collaboration with our trainees in the Global Brain Health Institute that come to train here in the Memory and Aging Center. These are people that come from all over the world. Many of them have a non-scientific background. They're artists or dancers, and they come here to learn about the brain. And with them, we've built this program of arts movement-based engagements that we take to these communities. And then lastly, and as we're doing work in these three areas, we're always talking about research. We're always talking about the clinic, and people naturally express interest in coming, sometimes coming here or coming to our community clinics because they're worried about something, or they want to participate in research. And so they come and join us here in our programs in the MAC. So we have created those pipelines of referral.
And that's amazing, of course. And the shared mission of just expanding sort of access to clinical care, but also kind of the tools to keep the brain healthy or to even hopefully prevent dementia to some degree and, open up avenues for contributing to research. Because, we're still obviously endlessly held back in some ways by lack of evidence, and lack of inclusion of people who identify as Latino, in research. So it's really amazing work. And I think as you continue to expand, especially on the clinical side, do you feel that there's, things from either a screening or a diagnosis or a care perspective for primary care that you feel you've learned in this outreach work, or just generally speaking as a specialist?
So recently I've been working with the primary care providers at the Mission Neighborhood Health Center to try to help them, because they do their annual health screens, and they reached out to me saying, hey, can we add a component around brain health? And we've been back and forth talking about how can we do this? And it's interesting because they come to me with questions that are similar to what we've already been talking about, which is like, well, how do I evaluate memory in this person who has no education? And they're telling me that they're fine. Their family is telling me that they're fine, but they're really doing terrible on the mini-cog, right? Or on some other, because they're using the mini-cog. And to me, that's very enlightening because, and this is something that I talked about in the webinar too, and that we've already touched on, which is, Yes, and people, providers, even primary care providers realize the limitations that they have, right? Obviously. And so there is, I don't, my belief here is that there isn't a good sort of magic bullet approach to evaluating cognition. So what I am turning back to with to them is uh, is is saying I'm sorry, but you're gonna have to spend more than 3 minutes. We're gonna have to ask these questions. You're gonna have to ask, to call the it's the approach of dementia care aware, basically, right? You're gonna have to get a collateral. You're gonna have to ask these questions. Um, and 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 do your best, knowing that you will have limitations, especially in those persons that come from a very vulnerable background, have no education, they may be illiterate, and maybe the best you can do for those people, as we've talked about in the dementia care aware webinars, is that the best thing you could do is just establish a good baseline, and just use that baseline as a point of comparison when you see them again next year. And maybe that's the best you can have, instead of worrying so much of like, what is the ideal test? What you should be thinking of is what is the ideal baseline evaluation that I can do on this person, knowing that my brief cognitive test is not going to be ideal. I'm not going to find it. And so that involves getting a good history from the person, getting a good history from someone that knows them well, doing the best brief cognitive test that you can, and lastly, but equally importantly, asking about their functional independence, right? How are they functioning? Because in the end, that's what matters the most.
That wasn't a plant. That was fabulous. Thank you, Sergio. Yeah, I think it's just a practical issue, and especially when we have a lot of folks who are in the Latino population, who have come from a million different places and have had all these different backgrounds. We just may not have a shelf ready assessment tool. And so I'm just going to kind of repeat what you said, because you did say it beautifully, but it also bears repeating. Like, between some sort of, really what you're talking about is just a clinical assessment baseline of what are their symptoms, if any, why would anybody think they're having any issues or any decline, and really what is the function, how is their day-to-day abilities being accomplished, and is there the need of another person to help with that, and then using that as a baseline to go from. Because the other key piece we're always looking for, as we're caring for over often years people who are living with dementia, if that's what's going on, we're looking for trajectory. So, time here, trajectory is going to be a huge help, when a baseline, if you will, like point in time assessment isn't going to tell us very much. We're just establishing what there is to know, how we can know that information, and then making a point to follow up. So yeah, I think it's a really good example of how, especially in primary care, we always want to help people. So if they have needs, if we identify needs, we always want to help with those needs in the moment. But in general, around the issue of, okay, is there an underlying neurodegenerative disorder that's causing a dementia syndrome? We're always able to use time as an additional diagnostic factor when we don't have these other, tools that are just totally perfectly calibrated for this person. Well, they're lucky to have you to help, because that's a luxury, but also such a resource. And I know they do amazing care and serve an amazing population. So really appreciate that they took the initiative to launch into that. That's pretty cool.
Yeah.
I think we'll unfortunately have to wrap up. This is a really rich topic. I think the other thing that your work has really highlighted is just how consistent and kind of forward you are with the brain health work, and how that can hopefully be helpful. And I just want to end with, do you think any reflections or anything you can help us think through, like if providers are listening who are trying to incorporate this kind of brain health talk into their practice, Are there things that you find are like particularly motivating for the people that you've done the outreach with around brain health? Like, how does it gain traction, and how do you guys frame it? Because I know that's something I'm always trying to do is like, essentially market it better so that people feel excited about
You
taking care
mean,
of themselves in this way.
okay. I think one way that we've created traction in when we are planning an event, for instance, around outreach, be it a series or a conference, we try to bring a sort of a positive um, health promotion type of is the angle, right? Rather than a disease-focused angle. So what I mean by this is um, much of the talks that we give, we will talk about the underlying brain diseases, but it'll be interspersed with a broader goal of like brain health promotion, right? So it'll be a series around learn what you can do or learn about the science pertaining to what keeps our brain healthy. And in there, we'll talk about what happens when your brain is unhealthy, when your brain develops a disease like Alzheimer's. But when you bring that approach, I think you engender a lot more interest because when you start from that point of view of like there are things that we can do to keep our brains healthy, there's more curiosity because if you start off with topics around dementia, Alzheimer's, people may shun away and be like, I don't wanna touch that because it's like what cancer used to be a long time ago. It was now, well, still an awful. It can be. I think it can be a real turnoff for many people. But now there's treatments, right, for cancer and for certain types of cancer are even curable. So that's changed a little bit. But I think what the idea that the public has around dementia is still highly sort of fatalistic and negative, and therefore people don't want to. I've had that experience where we frame things around Alzheimer's only or dementia, and we don't get as much enthusiasm as just brain health. I don't know if that answered your question, but that's what came
Yeah,
to
it really does. I was kind of just wondering like what is working, and I think what I heard is really the focus, the positive sort of angle of these are things you can do to be healthier around your brain and the way that your brain's going to do over your lifetime. Just like, you've had all these education or resources or marketing about your heart and your vision or whatever it is. And it's just that does seem to get an enthusiastic response. And I can see what you mean that obviously we're so focused on dementia and making sure that we know if people have dementia and we're helping them. But um, for the average person, it's not something that they're necessarily super enthusiastic about jumping into in and of itself. But the concept of brain health is obviously applicable to everybody. So
yeah.
yeah, that's wonderful. Well, we can wrap it up there. I know there's a lot of other avenues we could take to talk about this topic. And I guess it's sort of at the end here, but just to point out, I think one reason we really wanted to highlight the work that you're doing with Latinos is because we know that in general, this population is really underserved in terms of their needs for dementia and that there's huge disparities in detection. So I certainly hope that our conversation helps other providers and healthcare professionals think about how in their own practice or their health system, they could be using some of this information or at least learning from what we've talked about. And I just want to thank you again for spending some time to help share your wisdom and all that you've learned, and really appreciate it, Sergio. Thanks so much.
My pleasure.
Thank you for listening and to our wonderful guests. And a big thank you to our administrator and everything doer, Rita Archikova. Also, thank you to our audio editor and voice specialist, Lisa Costello. And we want to make sure you know you can get CE, CME, and MOC credits if you go to our website and click through to the podcast page, where you can do a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of the Dementia CareAware team. If you want to learn more, please visit our website, dementiacareaware.org.